And we are live. Good afternoon, everyone. Let me click on the Instagram go live. All right. So, good afternoon. This is Dr. Nelson with KiltzHealth. We are here on Thursday, the 22nd at 3 p.m., talking with Dr. Jesus Vega. Dr. Jesus Vega is a medical doctor, um, metabolic health practitioner as well. And where are you coming uh, from right now, Dr. Vega? Where are you located right now?
Oh, it's a pleasure to be here. I'm physically located in Mexico, in
Mexico.
a
Okay.
small city 2 hours north from Mexico City.
Okay.
Yeah.
I am in Florida, and wherever you are, welcome. You can, okay, Sandy just mentioned where she's from. Tommy from Temple, Georgia. United Carnivore from Tampa Bay. And let us know where you're coming from. Please like, share, comment, subscribe to help us with the algorithms. And you know what? I'm going to give. Do you eat any organ? Uh,
Oh yeah, I love liver. That liver
okay.
is by far my favorite one.
All right. So, how about that? We are going to give a bottle of grass fed beef liver supplements from KiltzHealth. And all you have to do is put the hashtag Vega in the chat. Hashtag Vega in the chat. And let me put it here. All right. So that was me putting in the chat. It's not Dr. Kiltz. He he might show up here, by the way. Sometimes he does.
Oh, fantastic.
So, uh, all right. So, Dr. Vega is a metabolic health practitioner. He has a couple of type of patients that he sees, some online, some in the United States or around the world. Do you see patients from other parts of the world?
Yeah, I do all the time. I work with Dr. Ford Brewer. You might have heard from him if you're watching the show. We have a channel, Prep Med Health, or you can just type Dr. Ford Brewer. Been working with him for a couple of years now. And on his practice, I have the role more of a health coach. So I focus more on lifestyle recommendations. And in Mexico, I'm licensed in Mexico. So on my practice, I can do more like I don't want to say the standard of medicine, even though I use some medications depending on the patient, but still we focus on lifestyle changes. So yeah, I do see both. I have some patients from abroad here and there. Sometimes I get some patients from Brazil, Colombia, Costa Rica. It happens sometimes. Yeah.
All right. So I would like to give you a scenario. Uh, we're gonna role play a little bit like we used to do when we were training with in medical school and sometimes residency, right? And I'd like to talk today, ask you about reversing type 2 diabetes. Now, many patients are not even aware that you can actually reverse diabetes. So we'll start with that scenario. Imagine a patient comes to the office, doesn't matter the age, but let's say he's 35. It's a frequent situation. Some people do develop diabetes early in their nowadays, even more and more. That there are type 2 diabetic children being diagnosed today in the world. And my opinion is that should never happen. but it's happening too often now. But let's say it's a 35-year-old female or male that comes to your office. You're giving them the news that they have type 2 diabetes, and you only have 15 minutes, 20 minutes to talk to them, right? Sometimes even probably less. What do you tell them about
So
reverse?
first, when we talk about reversal of diabetes and when we talk about the time frame, uh, fortunately for me, it's not a realistic situation where I can only spend 15 minutes with a patient. I usually my visits are usually 1 hour long at least. But it is the reality for a lot of practitioners over here in Mexico, and I bet that in the US it's basically the same thing. Usually, public health services over here, when you go to a public hospital, you have 10 to 15 minutes to talk to the doctor, and the only thing they will be all ready to do is prescribe a medication, and there you go, right? So we try to change that paradigm. Whenever I see a patient that comes to me, they don't know if they're dealing with diabetes. I ask for some lab results. They get with that. The first thing I will tell them is, okay, so we have reviewed your results. It is clear that you have a metabolic issue. It is clear that your glucose metabolism it's now on the diabetes range, and we need to do something about it. And first thing we want to do is make sure that you understand that a diabetes diagnosis is not a death sentence. It's not the end of the world. It's not a sentence and a label that you're going to have to carry on your back for the rest of your life. It is a treatable disease that we can even go back to your previous metabolism before you were diagnosed with this. The only thing that's going to be important to do is to start working on this. I like to picture the diagnosis of diabetes as a poisoning. If you have some type of poisoning, let's say lead poisoning or arsenic poisoning or cyanide poisoning, you name it. Whenever you go to the ER with a poisoning status, they will provide treatment, take out the poison out of your system, and make sure that you're not exposed to that again. And you're cured. You're cured from that poisoning issue. Diabetes is a similar situation in the side that we know what's making the problem happen, and that is refined carbohydrates, excess carbohydrates. You might have some genetic predisposition that is putting you in that spot, but at the end, it's the exposure to the environment, the exposure to those refined carbohydrates that are messing up your metabolism. So as long as we we keep those out and adjust your diet and lifestyle accordingly, why cannot we say that you can be cured? Just
Yeah,
like the poisoning, if you go back and expose to the poison again, you're gonna get sick again. Same thing here. If we go back to a pre-diabetes state and then you get exposed to that poor lifestyle full of carbohydrates and processed food and junk food, that's gonna come back. So it's a little bit of semantics, but at the end, reassuring the patient that he can get healthy even without medications. That I think that's the most powerful message that we want to bring out.
I call it the ultimate metabolic dysfunction because you have, along the same lines, you have multiple manifestations of chronic diseases that are coming from the same or similar process, but diabetes is the one that causes the most mortality. Now, I want to point out because I just mentioned mortality and that having diabetes, most people don't die from diabetes itself, right? They die from the complications of diabetes. And I want to show here. Let me see.
And while you look for that, there's one statistic that Dr. Brewer likes to bring out all the time.
Mhm.
We went into the details of the latest NHANES study. Turns out that at a little bit more than 50% of people 18 years and older, not even 20 or 30 or 40, 18 years and older, a little bit more than 50% of people have at least pre-diabetes or diabetes. They're just, most of them are just not diagnosed. And that's I mean, and that's based on the tests that they use, which is fasting glucose and A1C. We're not even counting all those people that might have some problems with insulin resistance that have not even been tested for that. So that's a very prevalent problem right now.
Yeah. So people that it's not a very big picture clear, but basically it's giving you an idea of the causes of mortality, whether it's increased percentage in cancer, infections, peripheral vascular complications, strokes, heart attacks,
Mm-hmm.
kidney disease, cardiovascular events in general. Uh, these are complications from the diabetes, which we define basically in the most simplistic form is elevated blood sugar, right? And usually on type 2 diabetics, there's elevated amounts of insulin as well.
Correct.
Um, all right. So,
And,
but
and
going,
if I may, Dr.
sure.
Nelson,
Go ahead.
that chart, if you see the chart and you had all the list of complications from diabetes,
Yes.
if there's one thing that they share in common is the mechanism in which diabetes is causing damage, and that is inflammation. All of those diseases share the same thing. Maybe infections is a little bit different because you need inflammation to target the infection. But diabetes itself decreases your immune capacity. So you are deprived from your healthy immune mechanisms. So that's one. And the second part is whenever you see guidelines about heart attack and stroke prevention, which is the main cause of death worldwide, um, they put diabetes as a major risk factor. But the thing is, they don't put pre-diabetes in there. They're not putting insulin resistance right there when it's basically the same disease. They're just waiting for it to become diabetes when it's too late. When you are now reaching 200 milligrams per deciliter on your blood sugar, when your A1C is going high enough, and at that point, it's too late. Some research suggests that by the point somebody's diagnosed with diabetes, 5 to 7 years have passed by with the problem. And through those 5 to 7 years, you are building inflammation, damaging your arteries, building arterial plaque, and doctors are not just not paying attention just because your A1C is not high enough just yet. And that's the sad part.
Yes. And there is, I believe it's the Arista study. I use a graph, a page with 3 graphs from, I believe is that study, where it shows all-cause mortality, cancer, and cardiovascular events in one side of the incidence, and on the other side of the graph is the A1C. So the line, the graph is flat. I'm sorry I don't have that at my fingertips right now, but on one side of the graph is the A1C, and the line basically is flat until you get to 5.6, and all of a sudden between above 5.6, the curves of those graphs is almost exponentially increasing for cardiovascular events, for cancer, for uh, all-cause mortality as well.
Mm-hmm.
So, but going back to our patient, has developed diabetes. You know, I don't know if it is the same situation with you, but for many years, most, I would say easily more than 95% of new patients I diagnosed with diabetes, they absolutely have no symptoms. The classic presentation of diabetes of polydipsia, polyphagia, and polyuria, that means
Yeah.
uh,
Eating too
drinking
much,
too
drinking too
much,
much water, peeing too
peeing too
much.
much,
Yeah.
and eating too much. I don't, yes, I learned that in school, but barely 5% of the times I diagnose someone with diabetes, especially not in the emergency room and not in the hospital, don't have any symptoms. Well, doc, I feel good. Yeah, my blood sugar is 200 when you did the finger stick, but I feel good. So sometimes telling the patient, you're almost hitting the panic button because you are thinking ahead 5, 10, 20 years where you can make an impact and avoid a complication, right? So, anyways, let's say you convince the patient, you gave them the information. What should we do? What steps should we take as far as lifestyle to try to reverse diabetes?
So first thing I want to do is listen to the patient. I think listening to the patient is one of those arts in medicine that is easily getting lost. Doctors are too tight on time, too tight on metrics, too tight on goals that they just can't listen to the patient. From those 60 minutes, I can tell you, I usually spend at least half an hour just listening to the patient. The first thing I do is, okay, let's talk about what is your current lifestyle? What are you doing now? And I get very granular on asking them, how is an usual day? How does a usual day go for you? At what time are you waking up? At what time are you eating? What type of physical activity you're doing? Where are you going? What are you doing? Getting very specific on that, because sometimes the devil's on the details. And then we start with the adjustments. Okay, let's assess, what are you doing now? What's your what's the amount of macronutrients, micronutrients you're eating? What's your eating window? What type of foods you're eating? Where are you getting those foods from? And then start adjusting. Some of the easiest steps to do is just getting rid of processed foods. That's one of the things. I can tell you my own personal experience. When I started doing a more like a keto board diet and started my journey, one of the first things I did was going to my fridge, going to my cabinet, and getting rid of everything that I wasn't supposed to eat. Because if you have it on your home, you're gonna eat it. So just getting rid of all of that, and then starting to plan according to a realistic setup of what you need to eat. One thing that I really see as a barrier for patients, and I see it all the time with my friends who are, I have a bunch of friends that are nutritionists. They come up with this specific diet and they tell the patient, you need to eat this, 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 and that, and these are the portion, and you need to do this and this and that. I bet that more than 90% of patients are not able to keep up with those types of diet. And I'm sorry, because that's what they went to college for, to learn how to prescribe that, and there's a lot of value on that. The problem is sometimes getting to eat the stuff that they're being asked to eat is too hard. You might not have the time to prep to cook it, you might not have the time to prep it, you might not have the time to get the stuff from the store or from a good place. So I rather go ahead and say, okay, we wanna know how much you're eating, but we're gonna focus on the foods that are easily available for you and that we know you're gonna eat, and not expect you to go get stuff that you're not just gonna be able to take or eat. And not we don't want perfection to get in the way with something that we can do. And if I may, I have one more comment in regards to symptoms. I agree 100%. Most patients will develop diabetes, and the point where they start developing symptoms is usually too late. Although I'm going to give you my personal experience. About 15 years ago, I'm 34 now. I would say when I was 19, 21 ish, I started going to hospital rotations during med school. My diet was the worst thing you can imagine. Even at med school, when I was in med school, bowl of cereal in the morning with a bunch of cookies on it, milk, just to get the energy going, right? That's what you're told. You need to eat enough energy in the morning so you can perform on school, right? Sitting on the bench of the school most of the day, not exercising enough. Of course, what needs to happen. I gained a lot of weight. And unbeknownst to me, I started developing pre-diabetes. I didn't have any testing. I was at med school, but I was not testing myself. So I was very naive. I gotta be honest. On one hospital, they were making this study where they were analyzing the temperature on the feet of people with diabetes. So the premise was people with prediabetes, diabetes will have a higher feet temperature because of the problems with blood flow and inflammation on vessels, including the vessels on their feet and legs. And they asked me, hey, would you like to be part of our control group? You're 21, 22 years old. You should not have diabetes or prediabetes, right? So you should be on the control group. They put me on the machine. They started measuring the temperature of my feet, and they said your feet are abnormally hot. This is hot feet on pre-diabetes ranges. You need to do something about it. And the naive of myself, I just said, no, this is gibberish. I didn't do anything. Life goes on. I should have listened at the time. But it's stuff that you don't realize. It's sometimes small symptoms: being tired, not having enough energy, foggy mind, not performing as you used to. Even erectile dysfunction at early age can be a symptom of microvasculature issues, not enough blood flow circulation and damage to the nerves. And people do not connect the dots. They will not imagine that their problem performing has to do with metabolic disease. So that's something that I usually talk about when anytime I have a young patient, because we have seen patients that once you look for that and you test them, you realize, yes, you're starting to develop metabolic disease even before your age 30. And we push our elderly patients to motivate their youngest to start getting tested, because it's usually too late when you're starting getting more of the clearer symptoms.
So on the diet specifically, what things do you advise them to begin with? It's difficult to make major changes in lifestyle, in diet, exercise, stress release, in problems with sleeping, all part of lifestyle changes. But you want them to start a few steps, in particular in the diet. Where do you start? Where do you start telling them maybe we should avoid this and maybe we should eat more of that?
There's one thing that I try to do, and I know it's hard for patients because sometimes we're too deep into the carbohydrate sugar addiction. So I don't like the approach or being too soft, where you tell them, okay, you can eat a soda per day or you can eat tortilla per day. You're fine. Just go ahead and do it. But I tend not to be very harsh either, because when you're telling them stop eating all the stuff you're addicted to, it's going to be hard. So I try to explain and let them figure it out by themselves what happens, so they get motivated themselves. So the first thing is assess the situation using two tools that we recommend. One, it's called a chronometer, which is an application you download on your phone, and it's basically a food log. And that food log is going to tell you, okay, how much macronutrients, how much micronutrients you're getting from your current diet. And they realize, most of my patients, when they start seeing me, that they haven't done anything or any change on their lifestyle just yet. They realize they actually have some level of malnourishment. They're not getting enough nutrients. Second thing is I pair that with a CGM, a glucose monitor, and this is a 2-week trial. You don't need me to tell you what's going to damage your body. You need to test it yourself. So food log everything you're eating, just 2 weeks. We're hoping that you're going to live 100 years. I'm just asking 2 weeks of your life to do this exercise. Log all the foods that you're eating for 2 weeks, then put a CGM on and see how your glucose behaves. Don't change your eating patterns. Do what you're doing right now. And then let's go back and discuss what we found. And then we decide, okay, of all the stuff, what can you give away right now? Most patients after week 1, they say, I'm going to quit this. Even before talking back to me, they will say, I'm going to stop eating this, and that. Once they realize that glucose is going to 180, 200, 220. And they start the change by themselves. So it's way easier, I have found, to let the patient see what happens with his body than just expecting them to listen to me. And then we start adjusting. Let's talk about healthy fats. Let's talk about healthy meat sources. Let's talk about even healthy vegetable sources that you like, that you're willing to eat. I don't I'm not on the perspective of eating fruit is bad. I realize about what happens with fructose. I realize about what happens with carbohydrates. But I do think that some fruits might have a role. I personally think that the problem with fructose is mostly because of high corn syrup, high fructose corn syrup. But I also don't recommend patients to overeat on fruits either. Most patients don't eat enough fruits anyway. So
I think
yeah,
I
that's kind of
think
my take.
I think the strength of the prescription on the therapeutic carbohydrate reduction depends on the level of metabolic disease that a patient has.
Mhm.
I think so. You have to individualize. Some people are just at the beginning of the curve. Some other people are way at the end of disease. So
Mhm.
when you see them, they've had for 30 years uh, diabetes. So it depends. And the problem with the fructose, which I completely agree, it's also on the doses.
Mhm.
In particular, someone tells, "No, I cannot stop eating fruit." I say, "Okay, well, do me a favor. Don't eat in between meals. Never drink your fruit. You want to have some fruit? You have it at the end of your meal after you have had
Absolutely.
your protein, your fat, your fiber if you're eating vegetables. Then enjoy your fruit. Why? Because it's going to always have some impact on the amount of glucose elevation, but you will minimize that glucose spike from the fruit if at least you have it. Because if you have it in between meals and on an empty stomach, or you're having it uh, juicing it, which I think is a sugar bomb, or if you want to have a breakfast is only fruit, probably the worst thing you can do. Even if I'm not saying the fruits are bad in that case, it's just that if you're only giving carbohydrates to your body to start with, you start your day with ups and downs on that blood sugar roller coaster, right?
Yeah, no, never eating carbohydrates on an empty stomach. Never.
So since the advent of CGMs, continuous glucose monitors, it's a lot easier to show the patients when I'm a little bit older than you. Uh,
You
when
you
I
can
went,
barely tell. You barely can tell. We look almost the same age. Maybe
yes,
it's
thank
the
you,
hair that gives us away.
thank you,
It's the
thank
hair,
you.
the only thing.
When I
Yeah,
went to school, there was no history class. It was called current events. Okay,
contemporary events. Yes.
so you know before the CEMs were available, and I use one myself, and they keeps me honest. But before, the only thing we still have that, and we can talk about accuracy as well of the finger stick glucose. Uh, that was the only thing. So I would tell a patient, for a few days, not always, but a few days, do it 2 or 3 times, 4 times in a day, and let's keep track of it, particularly after you eat, so you can see. But it was a lot harder to tell the patient, cause yourself pain with a finger stick. It hurts a little bit. It's not bad, but some patients can't handle that. Doing it 4 times a day, maybe 3, 4, 5 days in a row, uh, it was more difficult to convince patients to do that. Nowadays, with the CGM, if they get it, well, they can see the results. You don't have to teach them much after that because they see it if they pay attention. However,
So,
I do know some people that slap a CGM on them and then don't like to look at it when they're eating something they know they shouldn't be eating.
oh yeah, I have patients like that. They're like, Oh, I know my CGM is gonna go into the red numbers. I just won't even take a look at it. And sometimes they
Yeah,
need a they need a different kind of purpose and help to start defining they need to do something different. I see that mostly with the oldest people on Mexico, my crowd, who are the oldest patients who are not there because they want. They are there because their kids, their sons, daughters wanted me to see them because they're like, my mom is 81, 85, 90 years old. She has lived a plenty good life, but she's dealing with obesity and she won't give up the bread. And you understand, like, oh, well, she has lived through up until 90 years old with that problem. Yeah, but sometimes we have patients with significant comorbidities, other diseases related to that, and it's a little bit harder to make them understand. So we need to find a way to find a purpose for them so they are willing to make some changes.
that is a common situation because very often elderly patient, if you would, comes with their son or daughter,
Yeah, las
and
abuelitas. Yeah,
and
it's hard.
or sometimes it's the
Yeah,
grandchild, right? So they come with the, hey doc, tell them, him or her, how bad that is. So I go through the steps and I tell them, the problems with the different foods, but I also turn to the patient and grandchild or the adult child and tell them, you know what, I also believe if you're 80, 85, 90, you're pretty grown up, and we have to give them a little bit of grace,
of
because
course,
the truth is, at that point, w- changing the diet, it I think it always is beneficial, but the impact may not be as strong if we did that when they were 30s or 40s, right?
of
So
course.
I tell them, you know be loving. If they want to do it, fine. If they want to say, as long as they're in the right mind, uh it's really up to them to make the changes or not. And some people at that point, their bread, their fruit, the pasta, the starchy vegetables, whichever is their choice, um, is the way they're used to eating, right?
Well, and if I may add, what I have found on those types of patients, it's incredible. But usually, the biggest barrier is not the patient itself, but the family members, because they are telling you, "Hey, I want you to help me fix the diet from my abuelita," but they're not willing to make the changes themselves.
Themselves.
So they want to be eating whatever they're used to eating, getting all the tacos and tortillas and sopes and all that stuff, and they're eating that in front of the abuelita. No wonder she will not want to eat anything else. So this is a group effort and applies to any person, any age, but especially to the eldest. If you want somebody to make a change, this is a group, a team effort, and all the family needs to be on board. If somebody's bringing some snacks and stuff like that, just putting all that stuff behind their backs because they're feeling bad about the abuelita not being able to eat whatever she was used to eating, that doesn't work. And I agree with you, giving them some grace here and there, because at the end, I also have seen a lot of cases with depression. A lot of people, old people, have problems with depression over here, and if they're depressed, they don't have something to live for. They don't have any motivation to make any change.
Yeah. Carnivore Hercules made a comment. 14.7, now 5.6. Um,
Interesting. Is
I
that
I don't know
is
what the
that a
time frame was, but that's a huge change, right?
is that insulin
That's
or
a I think they
A1C?
were talking about A1C.
Wow.
Yeah. And I've
Yep.
seen those changes in as little as 3 months. I've
Yeah,
had patients with over
for sure.
15, and 3 months later they are down to 5 or 6. And off the top of my head, there are three I remember from the recent years that all they did was make what seems to be simple changes. Uh, two of them were Asian, and they stopped all noodles and rice. And both of them from 15.5, something like that, down to 6% at least. And the other one was a Central American lady who had a food truck. And, I see a lot of people from all these different Spanish countries because they seek me out. And it's so hard sometimes to tell a Puerto Rican don't eat rice and beans, or
Yeah,
Mexican, Central American don't eat tortillas
yeah.
and
We
rice
use
and beans.
tortillas instead of forks and
Yeah.
spoons. Yeah.
So all she did was stop all the bread and tortillas. And she was one of the few patients I've seen that came with symptoms, classical symptoms in the office. Blood sugar the very first time was, I think, 500. And
Wow.
she wasn't sick enough to hospitalize. Was probably one of the few patients I put on insulin, even if temporary. And by the way, by the next office visit, I had to take her off the insulin. Because at 500, you don't want to have any problems either. You can get very sick. So she, by the next visit, I have put her on a couple of oral medications, an oral hypoglycemic, metformin, and insulin on that first visit. By the next visit, I took the oral hypoglycemic out. I took the insulin out. I just left her on metformin, and she was doing great. So it can be very powerful sometimes, the changes that you see. Let me take a couple of the questions that are here.
Sure. And
And
while you look for those, one comment that I would like to make, and probably is obvious, but in our practice with Dr. Brewer, and in Mexico as well, whenever somebody goes on a low carb diet and then they see that A1C going down, the main cause of that A1C going down is definitely a low carb diet. It's one of the most evident changes that you will see.
meatitudes. uh, Docs, what are your thoughts? This has nothing to do with diabetes, but what are your
Well,
thoughts?
you might
What
say arterial plaque does have to do with diabetes, right?
What are your thoughts on the 3D mammograms that also test for arterial heart disease? Worth it? What do you think?
We don't usually do those kinds of tests. We have a very specific protocol to find coronary artery plaque or just arterial plaque. So you can start with a calcium score, even though it doesn't say anything about soft dangerous plaque. It can give you a first insight if you have any calcified plaque. If you have calcified plaque, you're very likely to have some soft plaque. You can do a CIMT, carotid intima media thickness test, which is a more less invasive, although it's not so available. That can tell you if you have any soft plaque, or a little bit quote unquote invasive test with an IB dye. You will have a CT angiogram, will show the coronary arteries and show plaque. That being said, we have seen patients that come to see us without any of those tests, and they only have like a chest X-ray or even an X-ray from neck or jaw, and they tell them, "Hey, this vessel over here has some calcification. You need to see a cardiologist or a preventive medicine doctor," and that's how they know they have some arterial plaque. So it's not the test we use, not because it doesn't work, but it's not as specific. So that's why we prefer use of the other ones.
Simpson Jones asked, "Did your study of measuring the temp of your feet show a correlation in insulin resistance?"
So I gotta say that study wasn't mine. I was just a medical student at the time. That was part of the doctors who were working at the hospital at that time. As far as I remember, they were testing diabetes alone. I don't think they even included pre-diabetes, and I haven't seen any new research that correlates that with insulin resistance. With diabetes, yes. With insulin resistance, no. And just it tells you tells you the current state of the art on that. We are still far away trying to find diabetes and not paying enough attention to insulin resistance. So I unfortunately I haven't seen anything on that space yet. Anything new?
A hashtag one or a number one, Savage asks, I have a friend with pancreatitis. She has been advised by doctors not to do carnivore. Can carnivore help?
That's an interesting question. So one neglected cause of pancreatitis is high triglycerides. So they are making the assumption that because if you do carnivore and eat a lot of fat on that carnivore diet, your triglycerides are going to go up. So
What will triglycerides do in most carnivore patients?
but that's
Go
the
up
question.
or down? Go
I
up or
haven't
down?
I haven't seen many people doing carnivore that have high triglycerides.
Yeah.
Some do,
It's
but
yeah,
I
it
usually find
happens.
because
It happens,
the
but it's
yeah
the
yeah.
minority.
So
Go ahead. Go ahead.
no, I mean it's hard to say this person will benefit from the carnivore diet. Correct. You might have another opinion on that. I know this is a carnivore podcast. My perspective on carnivore diet is that it has a lot of benefits, but I have also seen people who do not do well on carnivore. So for me, it's really hard to say that carnivore applies to everybody. Just like it's hard for me to say that a plant-based diet applies to everybody, or to say that a Mediterranean diet applies to everybody. My perspective is that the only diet that doesn't work for anybody is the standard American diet, or even the now trending sugar diet that we're planning to cover that in a few weeks because it's amazing how can people recommend eating sour patches and stuff like that as part of a healthy diet just because you lose weight and fat. Anyhow, that being said, we have seen patients and we have assessed patients that we have recommended carnivore diet if they're open to, and seen plenty of benefits. So it's hard to say by just one YouTube comment. Any recommendation needs to be individualized.
Yeah. On the triglycerides issue, I have seen it. People commenting, it's not common. Most patients, and you have to investigate if their triglycerides are high. There might be some genetic predisposition. You have to look for the cause, what's going on. But in most patients, triglycerides actually go down. So if the triglycerides are going up, also triglycerides like blood sugar, even cholesterol, fasting insulin, they're not static numbers. We all think, well, hopefully not my audience here because they're very smart, but uh, none of those numbers are static, right? They change hour to hour sometimes. So we have to be careful to compare the same test under the same conditions, uh, to be able to draw conclusions. And sometimes you just have to have a series of tests uh, to do that. All right. So continuing with the lifestyle changes, and I know you have to be going at the top of the hour, but in general, what other things, in addition to the diet, do you recommend as part of the lifestyle changes? And before
Probably the
before you
yeah.
say that, someone is asking, Dr. Vega, are you carnivore?
So if you define carnivore like only eating meat-based products, I'm not a carnivore. But I like to say that I'm on a meat-based diet. So I'm eating meat every week, but I am adding other stuff. I do eat some avocados. I do eat some leafy greens. I do eat some spices here and there. I eat some fruits, small fruits, especially before any workout. Um, and I eat some fermented foods as well here and there. So I'm leaning more on a meat based rather than a plant based diet, but I eat a little bit of everything, but processed foods. I think the only thing that is my uh, my thing that it's hard to left out is popcorn. So that's the only thing that anytime I go to the movies, I cannot see a movie without popcorn. But that's my own indulgence. I always say Dr. Brewer, he is very happy to say I'm eating ice cream 2 times a week, and he has very little other than maybe zero point 0.1 cubic millimeters of soft black. So yeah, I would say more like meat-based diet or keto diet for me.
Well, I used to think popcorn that does raise my blood sugar. So it's been years now since I've had that. But I used to think going to the movies, and I'm talking pre-pandemic, because
Pre-COVID, yeah.
uh, after the pandemic, I think theaters are having trouble with the numbers. But that's another story. Uh, I used to think, jokingly, I would say it's a sin to go to the movies and not eat popcorn.
Yeah, I know, and probably it's a cultural thing, or just that's the way I grow up. But yeah, I cannot stop doing that for now. But I don't have any popcorn inside my house because I know if I have it, I'm gonna eat it all. So that's just the way it works.
All right, we have a question here, and I did ask you about other lifestyle changes, but let's say this question, and then we can cover what other lifestyle changes you recommend your patients. Doctor, so and so said diabetes is a vascular disease. What does it mean?
So whenever we say diabetes is a vascular disease, we're talking about blood vessels who are everywhere, almost everywhere in your body, right? That includes brain, eyes, lungs, heart, gut, skin, legs, nerves. Like your nerves themselves have their own small micro vessels that feed them of blood and nutrients. In your penis, your genitals, they are tons of vessels. And blood sugar, which is transported on those vessels, whenever it's elevated, it's basically a poison or toxic. There's one thing that I learned from Dr. Brewer a few years ago, and he said, um, "What do you think people say that sugar or carbohydrates are the main source of energy? Why is the body, the metabolism, using sugar as the first source of energy? That's because too much sugar in the bloodstream damages the vessels. So anytime your sugar goes up, your vessels get damaged, and your body's trying to minimize that. And it minimizes either if you're exercising, using that energy to move around, goes to your muscles. If you're using your brain uses glucose as well. But if you're not making any kind of effort, it's going to turn that excess glucose into fat and it's going to store it in your fat cells. But one way or another is going to try to balance and minimize the amount of sugar that you have in your bloodstream. But when you develop insulin resistance, pre-diabetes, diabetes, your body gets less and less capable of getting adapted. And that's when your blood sugar goes up, 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 and up. And excess sugar is going to damage your vessels. And here's the other part. High insulin does the exact same thing, although insulin is not as inflammatory as glucose is. But excess insulin, it's also going to damage blood vessels. And how do you get excess insulin? Well, by chronic excessive exposure to high blood sugar. So I have seen even some memes and notes from other people saying, you know what? All this keto crowd is too worried about a normal physiology. Anytime you eat carbohydrates, your sugar is going to go up and then it's going to go down. And that's absolutely normal. And I will say, spikes might be normal. That's how the body is made to do. The problem is, most people do not have only one spike that comes back down quickly. And chronic exposure to those spikes, they will end up developing insulin resistance, especially when that glucose remains over 140 for a longer period of time. There's one book wrote by Jenny Rule Blood Sugar 101, where she found some research paper showing damage to vessels and nerves when you have prolonged exposure to 140 or more blood sugar levels. Um, and that's the problem. That's why we're trying to find healthy people with the CGM to make sure they're not on that roller coaster of very high glucose and insulin over time. I will agree. Having a spike, that's maybe a spike 2 times a day, it's not such a big issue. But when you're too deep into this, which most people are, you're going to have way more than that. And that's the main problem. And that's why it's a vascular disease.
As a rule of thumb, what do you tell them as far as the glucose spikes? Uh, what what will be a normal spike and for how long, as opposed to it's too high or for too long?
What I have seen is the optimal should not go over 140. If it goes over 140, I'm not too concerned either, as long as it goes back down within the hour. The problem is when you have spikes going to 180 to 100. That's a big issue.
And
That
even if it went, near, above 140 and not perhaps to 200, but if it was back, let's say in 2 hours, it's not the same as going up and taking 6 hours to come down
exactly.
to the baseline.
And that's why whenever testing for diabetes, pre-diabetes insulin resistance, we do recommend the oral glucose tolerance test with insulin response. It's not a fun test at all. We understand that it's challenging, but it's the test that's going to identify more than 95-99% of cases of insulin resistance,
Do
because we
you,
have seen. I'm sorry.
when you have it done, do you order it for how many hours? 2, 3, 5?
We do the 2 hours only. We
Okay.
do fasting 1 hour, 2 hours. We sometimes recommend the 30-minute mark as well. Um, it depends also on the patient's perspective. I have done that test twice. That's how I identified I had pre-diabetes. Because sometimes we have seen patients where their glucose response looks good. They're not going over 140 and they're going back down really quickly. But when you see the insulin response to that glucose, their insulin goes to 60, 80, 90, 100, and their blood sugar is normal. So if you only do the glucose, you might not be able to see the insulin behavior. And when your insulin goes that high, that is one of those subtle signs of insulin resistance. So you might not have prediabetes, you might not have diabetes yet, but you're clearly pushing way more insulin than you need to keep that sugar down. And that's a sign of insulin resistance.
Uh, I think the hemoglobin A1C is a wonderful test, but it's not necessarily a perfect test, number one. And many people don't know this. Uh, you're very young that you
I
might be
appreciate
in
that.
that group because A1C was not a diagnostic criteria for diabetes until 2009, I believe, or 2010, as a diagnostic criteria. There are three others still valid uh, diagnostic criteria for diabetes. By the way, when I graduated from medical school, the fasting blood sugar that you were looking for was to be 140. Now we use 126 for many years as the mark, right? So two fastings over 125, that was one diagnostic criteria. Random blood
Mm-hmm.
sugars with symptoms over 200, or an abnormal glucose tolerance test with specific
Yeah.
elevations. Those were the three classic uh, diagnostic criteria. Hemoglobin A1C was used as a backup to confirm, but as a diagnostic criteria is very young in the history of medicine. It's
Yeah.
been
And there's even there's a study where even the American Diabetes Association shared that at least one study that has found that A1C can miss up to 70% of cases of diabetes. 70% of cases. And that's because A1C is based on hemoglobin, as you mentioned.
Mhm.
And there are a lot of other factors that can affect the hemoglobin that might damage the result. I can give you my example, which is not a common example. I gotta mention that. Uh, at the time when I did my oral glucose tolerance test and my blood sugar spiked up to 160 something, 180, uh, my A1C was 3.4. And they called me from the lab and they said, you know what, can you please come back again? We would like to take another blood sample, retest it, and get some extra testing because this is not normal. Granted, I have a specific genetic modification on some of the proteins on my hemoglobin that don't allow my A1C going up. So had I relied only on fasting glucose on or A1C, I probably didn't will not identify that I have a problem. Uh, but again, granted, it's not most patients that will have 3.4 on their A1C, but a lot of patients will have abnormally high or abnormally low A1C because of thyroid issues, iron deficiency issues, and other stuff.
So someone commented this, and I want to clarify why I thought A1C was pretty valid test for diabetes. It is a valid test, okay, but there are circumstances with people with hemoglobinopathies, any abnormality of the hemoglobin, multiple. For example, sickle cell patients uh, have. You cannot rely on the A1C. In those patients, you need to use other methods of diagnosis. So it's not that it's not a valid test, it's that we have to recognize no test is perfect.
Mm-hmm.
And when you use the test, you need to know that under certain circumstances, that test might not give you the whole picture. Listen, we're coming up on almost the top of the hour. 1 minute, please. Other lifestyle changes besides diet that will be helpful for diabetes.
That's a really challenging one. So muscle mass is a big one. We have a lot of elderly patients, but even if you're young, muscle mass is important. As long as you don't sacrifice your metabolism for a good for good muscles and looks. Uh, I think we like to call them chats. Those guys that go to the gym, your typical shredded guys, who
Mhm.
they're usually their diet is based on protein and carbohydrates, chicken and rice, right? And there's some truth to that. Like eating carbohydrates will definitely improve the amount of muscle mass that you're gonna do. So that's why I'm open to use some not processed, not refined carbohydrates, some fruits, some vegetables, even I don't really like whole grains that much, but any carbohydrate that's gonna maybe rise your blood sugar right before or right after your exercise routine. You can do some aerobic exercise. Walking alone helps, but I'd rather use something more like weightlifting, resistance training, doing high intensity interval training where you go into your treadmill, your bicycle, or just even doing squats or burpees and you get your heart rate as high as possible, go as hard as you can for at least 1 minute and then rest and then repeat. That stuff is really helpful. Of course, we don't go to high intensity interval training right away. We start with something mild and then we move forward. But getting stronger muscles is a must to get into healthy aging longevity. Sleep is another one. I rather use sleep hygiene methods rather than supplements and medications. Some people will need those, but just by fixing their sleep hygiene usually is enough. Not drinking too much fluid, getting kind of a ritual before going to bed, a hot bath, getting relaxed, no phone, no tablet, no light before going to bed while you're feeling sleepy, not before that, not eating on your bed, a bunch of other recommendations to improve sleep. Minimizing stress, getting healthy relationship with people, with friends and family, um, and avoiding environmental toxins. Those are kind of the mildest issues, but avoiding microplastics, trying to avoid EMF radiation, other stuff that can be minimized can help a little bit. Um, at the end, I think the pillars are the diet and exercise, of course, and then it comes medications and supplements, which there's a wide range of those that depending on what your problem is, that's what we tackle.
And there's a place for them in helping with this whole thing. But like you said, diet and exercise, it's probably the foundation of what you need to do. Well, thank you very much, Dr. Vega. I,
My
I want
pleasure.
to stick with the plan. Tell me where we can find you. While he tells me where we can find you, I'm gonna do the giveaway. So
Okay.
where can we find you, Dr. Jesus
Uh,
Vega?
just reach out PrepMed Health. Go to Fort Brewer on YouTube, or you can call us 859-721-1414. Dr. Brewer is licensed in all 50 states, and we have a group of health coaches that can help you with that as well. We're trying different programs that we're trying to get to more people.
Well, thank you very much,
And
Paul Clark.
congratulations to Paul.
You need to email Alia, ALIA, at drkiltz.com, Alia, Dr. Kiltz spelled out.com, and we will send you the liver supplements. Have a
Fantastic.
great day. Thank you very much, Dr. Vega. You've been very kind because you've been in our Zoom calls also for, but the past 3 weeks you were twice there.
My
So
honor. It's my
thank
honor.
you
I
again, and
appreciate the invitation.
we'll have you in the future as well, and probably in a Spanish channel.
Oh yeah, of course. Absolutely. My pleasure. Get a bounce. Thank you. Take care, y'all.
Goodbye, everyone. See you tomorrow morning at 6 a.m.